Hi, I'm Alexandros Rekkas. I'm a PhD student at Erasmus Medical Center. And I'm going to be talking about the development of a standardized framework for the assessment of treatment effect heterogeneity in observational data using a risk-based approach. This work was done under the supervision of David van Klaveren and Peter Reinbeck from Erasmus Medical Center, and with major contributions from David Kent from Tufts Medical Center, Eva Steyerberg from the Leiden University Medical Center, and of course Patrick Ryan from Janssen. So the framework that we developed works in 5 steps. So in the first step, we define the problem that we want to study. So we need to define a treatment cohort, a comparator cohort, and 1 or more outcome cohorts. In the second step, we identify the database that we want to use, and we apply our cohort definitions using, of course, OMOP and Atlas and all this stuff. In the third step, we develop prediction models for the outcomes that we're interested in. And we do so by pooling the treatment and comparator cohorts into a target cohort, and then we develop prediction model. Then we predictions that we got from the previous step, and then we estimate. Then we first run some diagnostics on both on the entire population and within the risk strata to see that these are the typical diagnostics that we run using the cohort method package, and that are commonly used in the Odyssey within the Odyssey community, like propensity score, preference score distributions, and covariate balance and negative control analysis, stuff like that. And then if everything looks fine, then we can proceed with the actual estimation, both overall on the entire data sets and within risk strata. And we do these estimations both on the relative and on the absolute scale. So within each risk stratum, we actually develop a new propensity score model, and then we do the propensity score adjustment and estimate relative control, the relative treatment effects and absolute treatment effects. And in the final step, we basically, because this can be done across multiple databases, then we combine all these results into an easier way to evaluate these results. This whole process can be run with the R package that we developed called the risk stratified estimation, and it's available on the Odyssey GitHub. So for this paper, as a demonstration, we used a sub-problem from the Legend hypertension study, and namely the comparison between thiazides or thiazide-like diuretics and ACE inhibitors. And we did this comparison across the three IBM databases that we. Namely acute myocardial infarction, hospitalization with heart failure, and stroke, and another 9 safety outcomes that we'll see later. Now, for the prediction step, we developed separate acute MI risk prediction models within each database. However, we use the same cutoff points within each database. So we separate the population into 3 risk strata. The low risk patients that are below 1% acute MI risk, the intermediate risk patients that are between 1 and 1.5% baseline risk of 2-year acute MI, and the higher risk patients that go above 1.5% risk. From table 2, we see, like in the final row, that our prediction models had adequate performance in CCAE and MDCD, and a little bit lower in MDCR regarding discrimination. Now for the estimation step and the evaluation of some diagnostics. So when we look at these preference score distributions across risk databases and risk strata, we immediately see that in CCAE there may be a problem, especially in the higher risk patients, where we see that the distributions are a bit separated. This is also confirmed in the covariate balance plots, where we see again that in patients at higher acute MI risk, the balance is all over the place, and so yeah, results in this specific risk group may not be so trustworthy. However, we see that in other cases as well, there might be some problems. So, for example, in the lower CCAE risk patients also, or in MDCD. So again, the problems in CCAE are confirmed again in this in the negative control analysis, where we see that there may be some evidence of residual confounding going on in CCAE. So because of the problems with CCAE and mainly because these problems are focused in the higher risk patients, we don't consider anymore the highest risk patients in CCAE, and we only present results for the lower and the intermediate risk groups in CCAE. Yeah, so we first have a look at the relative determinant effects and namely the overall results. So on the entire data set and not risk stratified. So we see that, as was the case in the Legend hypertension paper, we see that we find that thiazides or thiazide-like diuretics are perform better compared to ACE inhibitors for these three outcomes across the board, except for maybe so in CCAE, in hospitalization with heart failure, we see negligible differences, and in MDCD for stroke. Yeah, so for the main outcomes on the relative scale, we see that when we look at this, there are no specific trends going on here across with increasing acute MI risk, except maybe in acute MI for the acute MI outcome, where we see that on the relative scale, the benefits with thiazides become less pronounced as we go higher in acute MI risk, but nothing specific in the rest outcomes. And when we look at the 9 safety outcomes that we considered, some things pop up right away. So we first see the significant, the important risk increase of angioedema and cough, and yeah, with ACE inhibitors, and also on the other hand, on the opposite side, the risk increase with thiazides for hypokalemia and hyponatremia as well. So these are the results in the relative determinant effects. But then when we look at the absolute determinant effects and then try to understand a little bit better what's going on. So for the main outcomes, now in this case, we see some clear trends, and especially for acute MI, where we see that benefits with thiazides increase as acute MI risk increases. So patients at higher acute MI risk tend to observe higher benefits compared to lower risk patients, and especially with patients below 1% acute MI risk, there's almost negligible differences anymore. There are no differences anymore. This trend is a bit less pronounced in the case of hospitalization with heart failure, and we don't see any trend. We see no differences in the case of stroke. And but when we again look at the safety outcomes now, things become a bit more complicated. So we see that with thiazides, of course there are benefits. So there's a lot of absolute benefit in the case of cough and hyperkalemia, but on the other side, there are significant and strong risk increases of hypokalemia and hyponatremia as well. So if we try to figure out a little bit what's going on here, there are four things that we can conclude from this study. First, that the overall benefits that were found in the latent hypertension study, it's not that easy to translate to individual patients. Second, this is because it seems that the overall benefits that we observed were mainly driven by high-risk patients, whereas third, they're all lower-risk patients didn't see so much benefit. So yeah, so the overall thing is that provided that the absolute benefits of thiazides for the main outcomes were mainly observed in patients at high acute MI risk, then it turns out that the prescribing physician needs to carefully weigh benefits and harms for individual patients. Yes, that's it. Thank you very much.